Hey there, book podcaster crew. So, if you're maybe feeling a bit like our friend, the nursing student who's always studying, brain totally full,
Yeah, trying to cram everything in. We get it.
we've definitely been there.
Mhm.
So, maybe take a quick mental break with us. We're going to dive into a topic that can seem pretty heavy: bipolar disorders.
Yeah, but think of this less like another textbook chapter and more like us just talking it through.
Exactly. Our mission today for Between Extremes, Understanding Bipolar Disorders, is just to make it all feel a bit clearer, maybe less daunting.
Right. We've sort of sifted through the main stuff for you, the definitions, the science, some real life stories too.
They
Try
don't
and
have
pull out the key things so you can get the essentials.
Okay, awesome. So let's just jump in. Our source, Townsend, it defines bipolar disorders as, well, mood disorders with these really big swings.
And not just like a bad day, good day kind of thing.
No, exactly. We're talking serious shifts from like deep depression way up to intense euphoria or mania.
Yeah.
And then sometimes periods of feeling, more normal in between.
And the degree of those shifts is really key here. How much they change someone's thinking, their energy, their behavior.
Yeah.
It's not just feeling a bit moody. These episodes can really mess with daily life.
Right. Let's take Chloe, for example. She's 28, a graphic designer. Imagine her just like buzzing for days, hardly sleeping, totally convinced she's creating this genius artwork,
Okay.
churning out designs like crazy, right? Super inspired. Then boom, the switch flips. A week later, she can barely get out of bed, totally drained, can't function. That huge contrast is what we're talking about.
Yeah, that's a really good illustration. And Chloe's experience kind of leads us into the different types of bipolar disorder. It's not just one thing.
Ah, right. It's more of a spectrum.
Exactly. There are three main types that are important to know.
Okay, what's the first one?
First is bipolar I disorder.
Mhm.
The main thing here is having at least one full manic episode.
Just one.
At least one, yeah. And often, though not always, these manic episodes come before or after depressive episodes. So, think about John. During mania, he might lose his inhibitions, go on huge spending sprees, max out credit cards.
Wow.
Then that high crashes, and he could fall into this really deep, awful depression. That up and down between extremes is classic bipolar I.
Gotcha. Okay, then what's bipolar II?
Bipolar II disorder. This involves having at least one hypomanic episode. Notice the hypo, it means less severe mania, and also at least one major depressive episode.
So hypomania is different from full mania.
Yeah, that's a
Yeah.
key distinction. Both involve higher mood, more energy, but hypomania isn't usually as intense. It doesn't tend to cause the same level of problems with work or social life or need hospitalization like mania sometimes can.
Okay.
Like Alicia, she might have a few days where she's super productive, tons of ideas, doesn't need much sleep. That's hypomania.
Right.
But then she'll have weeks of feeling incredibly sad, no interest in anything, just exhausted, the major depressive episode.
Okay, that makes sense. And the third type?
That's cyclothymic disorder. Think of this one as more chronic, sort of fluctuating moods. Periods of mild hypomania and mild depression, but they go on for at least 2 years in adults.
But not full episodes.
Exactly. The mood shifts are noticeable, but they don't quite meet the criteria for a full manic or major depressive episode. Like Ramon, he has these ongoing ups and downs, feeling more energetic sometimes, then more down later. But it's not severe enough to be diagnosed as bipolar I or II. It's like a persistent pattern.
Okay, so that lays out the different types pretty clearly. Now let's maybe zoom in on what mania and depression actually like look and feel like. What are the specific signs?
Sure. Let's start with mania and hypomania. For mania to be diagnosed, the symptoms need to last at least a week, or really any duration if someone needs to be hospitalized because it's so severe.
Okay, a full week.
Yeah. Hypomania, the threshold is a bit shorter, at least 4 days in a row.
Got it. So what are we looking for?
Well, a big one is inflated self-esteem, which can blow up into grandiosity, like believing you have amazing powers, or are incredibly important. People in mania often need way less sleep. They might feel totally fine after just, say, 3 hours.
Wow.
You also see pressured speech, talking super fast, hard to interrupt, and racing thoughts, sometimes called a flight of ideas, where thoughts just jump all over the place.
Sounds intense, like your brain's on fast forward. What else?
Yeah, definitely. Distractibility is common too, can't focus. Often an increase in goal-directed activity, like starting tons of projects at once, or psychomotor agitation, just being really restless, fidgety.
Okay.
And finally, a really important one, risky behavior. This could be anything from spending tons of money, impulsive sex, reckless business deals. Basically, acting without thinking about the consequences, like feeling invincible.
Yeah, you can see how that could cause major problems. Okay, now let's flip to the other side, the depression. What are the signs there?
The symptoms in the depressive phase of bipolar disorder look a lot like major depressive disorder. So, feeling sad, hopeless, empty most of the time, losing interest or pleasure in things you used to enjoy, feeling really tired, no energy, lots of guilt or feeling worthless,
Right.
trouble concentrating, remembering things, making decisions, and sadly, thoughts about death or suicide can be part of it too.
It's such a stark difference from the mania.
Yeah.
We actually have a real-life insight about Felix that really shows this. During mania, he said he felt invincible,
Invincible, yeah.
started 5 businesses at once, and even tried to fly a drone into an active volcano for YouTube.
Wow, okay.
Ah.
That's definitely grandiosity and risky behavior right there.
Totally. But then the crash.
Right. And that's the critical part. Felix didn't just gradually come down. He plummeted into a depression so bad he was having suicidal thoughts. That huge swing shows the intensity and, frankly, the danger.
Yeah. Like his brain went from full throttle to completely stalled out.
Exactly.
That's a really powerful story. So, okay, what's actually causing this? What are the underlying factors or risks for bipolar disorders?
It's definitely complex, not just one single thing. The current thinking points to a mix of biological factors, psychological stuff, social things too.
Okay, let's unpack the biological side first.
Genetics are huge here. Our source mentioned a really high heritability, like 60 to 80%.
60 to 80%?
Yeah, it's one of the most heritable psychiatric conditions. So having family members with bipolar disorder definitely increases your own risk significantly.
The strong link. What about brain chemistry?
Neurotransmitters, yeah.
Yeah.
Chemicals like norepinephrine, serotonin, dopamine, they're key players in mood, energy, sleep.
Hmm.
Imbalances in these systems are thought to be a major contributor to those dramatic mood swings. It's like the brain's communication network gets disrupted.
Makes sense that if those chemicals are off, your mood would be too.
Yeah.
Okay, what about psychosocial stressors, like trauma or big life changes?
Well, they aren't seen as causing bipolar disorder directly, but they can definitely act as triggers for episodes in people who are already vulnerable.
Okay, so they can set it off.
Exactly. Big stuff like trauma, losing someone, major relationship issues, even just messing up your sleep schedule. These can all potentially kick off a manic or depressive episode if the predisposition is there. It's like throwing gasoline on embers.
Right, and substance use. That often comes up with mental health.
It does. And with bipolar, stimulants like cocaine or amphetamines can be especially tricky.
How so?
They can actually mimic manic symptoms or even trigger a real manic episode in someone who's susceptible. Plus, it gets complicated because sometimes people with bipolar disorder might use substances to try and cope with their symptoms, which, often backfires.
Yeah, a difficult cycle. Okay, so we've talked about what it is, the types, symptoms, causes. Now, how is it treated? Medication seems like a big part of it.
Absolutely. Medication is usually crucial for stabilizing mood, making episodes less severe or frequent, and just helping people live better. The main types are mood stabilizers, anticonvulsants, and atypical antipsychotics.
Let's start with mood stabilizers. I feel like lithium is the one people hear about most often.
Yeah, lithium carbonate, it's been used for a long time and is often seen as the sort of gold standard, especially for managing mania and preventing it from coming back.
But it needs careful watching, right?
Extremely careful. It has what's called a narrow therapeutic range.
What does that mean exactly?
It means the dose needed to be effective is pretty close to the dose that can cause toxic side effects. The sweet spot in the blood is usually between zero point 0.6 and 1.2 millieql. Go too high and you get lithium toxicity.
Okay, and what does toxicity look like? What should people watch out for?
Early on, it might be things like hand tremors, feeling sick, vomiting, diarrhea, just generally feeling unwell. If levels get higher, it can get more serious confusion, muscle weakness, slurred speech, even seizures in severe cases.
Wow.
We have that medication monitoring tip about Serena. She had the tremors, vomiting, diarrhea. Her level was 1.9 millieql.
Way too high.
Way too high, yeah. Toxic. So the immediate steps are critical. Stop the lithium, push fluids, call the doctor right away.
That's really vital information. So besides lithium, what other mood stabilizers are used?
Anticonvulsant meds are common too. Drugs like valproic acid, carbamazepine, lamotrigine. They were first for epilepsy but work well for mood swings.
Interesting.
And then there are atypical antipsychotics, olanzapine, risperidone, quetiapine. They can help with both mania and depression and also for long-term mood stabilization.
Okay, so meds are key. But it's not just medication, is it? What about other kinds of support? Like, what do nurses do?
Oh, nursing care is absolutely essential. Nurses are really on the front lines, providing that day-to-day care and support. And what they do changes depending on if the person is in a manic phase or a depressive one.
Okay, let's take the manic phase first. What kind of help is needed then?
During mania, the big goals are safety for the person and others and reducing stimulation. So think quiet environment, low lights, fewer visitors maybe.
Right, try to calm things down.
Exactly. Clear, consistent boundaries are super important too, because impulse control can be low. And since they might be too agitated to sit for meals, offering finger foods, high-calorie stuff they can eat on the go helps with nutrition.
Smart.
Plus, redirecting risky behaviors safely and just monitoring sleep, food, hydration closely.
Makes total sense. So creating structure and calm.
Yeah.
What about during a depressive phase?
Yeah.
How does the nursing support shift?
Then the focus changes. It's more about encouragement, supporting them to maybe start doing things again, even small things, when motivation is zero.
Gently encouraging activity.
Yeah. And assessing suicide risk is always a priority. Therapeutic communication is huge too, using open-ended questions, showing empathy, really listening, helping them feel understood, not so alone.
You mentioned therapeutic communication, and there's that great example phrase, like instead of saying just calm down.
Which can feel really
Yeah.
invalidating, yeah.
Right, try something like, I see you're feeling really energized right now. Let's maybe go to a quieter space so we can talk.
Exactly. It acknowledges how they feel, but gently guides them. It validates without minimizing and offers a helpful step.
That's a great practical tip. Now, to kind of bring this all together, we have Maria's story. Can you tell us about her?
Sure. Maria, 35-year-old nurse, she was admitted during a manic episode. She'd suddenly left her job, flew to Vegas impulsively, gambled away her savings,
Wow.
hadn't slept in 5 days, and had these grandiose ideas about having a divine mission for healthcare.
That really captures the mania, clearly. How did treatment go for her?
She was started on lithium, which helped stabilize her mood. She also did therapy, both one-on-one and group.
Mm-hmm.
And over time, with the medication working and her learning coping skills in therapy, her mood evened out. She was able to eventually go back to work as a nurse with ongoing outpatient care and support.
That's such an encouraging story. It really
Mhm.
shows that recovery and managing bipolar disorder is possible.
Absolutely.
So wow, we've covered a lot today. The basic definition, the different types, the symptoms of mania and depression, the causes, treatments like medication and nursing care. And Maria's story ties it all together.
And stepping back, just understanding this stuff is so important. Bipolar disorder affects a lot of people. And the more we learn and talk about it, the less stigma there is.
Yeah, totally. Creating a space where people feel okay seeking help.
Exactly.
It can definitely feel like a ton of information. I get it.
Right.
But the main things to take away are it involves big mood and energy shifts. There are different types. And treatment works usually a combo of meds and support.
Mm-hmm. And like Maria showed, managing it and living a full life is definitely achievable.
For sure. So if you're feeling like that nursing student with information overload right now, just remember, breaking down complex stuff piece by piece. That's how we learn. You made it through this deep dive, and that's awesome.
Yeah, you really did.
You've got this. And seriously, remember to take care of your own mental well-being, too. It's just as vital as everything else.